All right. Got it. All right. Our next speaker is Dr. Patrick Reid. He comes to us after attending medical school at Rutgers and then completing neurosurgery residency at Rutgers and USC, and then 2 fellowships, an unfolded spine fellowship at HSS, and then a fellowship in spinal deformity and tumor at UCSF. He is now the chief of neurosurgery at Mount Sinai Morningside and director of Spinal Neurosurgical Oncology throughout the health system. Really looking forward to hearing you speak, Dr. Reid.
Thanks very much, Chris. Thanks for having me. Thanks for not sharing any pictures of me during my residency. You guys all look pretty good. I consider dissemination of any pictures. So I'm going to talk today about something that's very interesting and I think important to me, essentially the treatment, how we're treating metastatic spine tumors today. Basically with a 30,000-foot view of our practice and what I've been doing for the last 4 years at Columbia, and we'll try to do moving forward here, but then also how we got here, and specifically how we got here with regard to the decision making, which I think of as the most interesting and probably important aspect of this process, the process of taking care of these patients. So about 30 minutes, I'm going to go quick. I have some disclosures, Medtronic and therapeutics, none of which pertain to this talk, other than Medtronic is in talks to fund some of my research on spine tumors, specifically about vertebroplasty, augmentation of screws, and spinal alignment. But we can talk about that later. I'll start with just a little vignette from my time uptown back April 2nd, 2019. A woman came into my office. She was 56. 5 years earlier, she'd been diagnosed with an endometrial sarcoma, after which she'd undergone a hysterectomy. She'd had immunotherapy and done well. Unfortunately, in 2016, she began to develop back and leg pain, which ultimately seemed to be due to an L4 pathologic burst fracture. At least that's the best we were able to discern. At that time, she underwent an L3 to L5 decompression infusion, and then what we think of as conventional radiation, 30 gray and 15 fractions. And then it done well, but she appeared in my office with back pain and leg pain, keeping her from walking around, just awful pain at all times. She had these films, these standing x-rays. You can see the L3 to L5 construct. And while this looks okay, it does appear that there's some loss of lordosis at L5. And on closer inspection, on CT and MRI, you can see that while L4 is in all likelihood similar to how it looked several years ago, it seems like that's been well treated. L5 appears to have a pathologic burst fracture that's causing both some loss of lordosis there, as well as some stenosis throughout the canal, and some infestation of tumor in the L5, likely causing all kinds of problems in terms of her construct, resulting in axial back pain, understandably, and from her stenosis, particularly on the left side, she had a fair amount of leg pain. So about 2 weeks later, after a lot of discussion with our team, our radiation oncologist, her oncologist up in Connecticut, and the patient herself, we ultimately started moving forward to treat this, right? So first, on the 18th, she underwent an embolization of the tumor at L5 in particular, and also some treatment at L4. The following day, she went for a big surgery, right? So this is a T11 to pelvis operation. We did an L5 corpectomy, decompressed all those nerves, and essentially reconstructed through the lumbar spine. I'm going to go into too much detail about this, except that it's a lot of surgery for someone with metastatic cancer. Did well, ultimately was discharged from rehab on the 6th of May, right? So that's about 3 weeks later. And then on the 15th, followed up with our radiation oncology colleagues, where they delivered a hypofractionated radiosurgical dose, I believe over 4 fractions, to essentially every bit of tumor they could find. For the tumor bed at L5, they did a revision treatment at L4. And on July 2nd, she came back in follow-up. It was approximately 3 months later, doing very well, walking, functioning essentially at a much higher level than she had been when she came in, more or less pain-free. And while she was still being treated for her tumor recurrence, we were certainly happy with her from a spine perspective. So there's a lot of interesting things about this. If you're a guy like me, you think the construct and the techniques are neat, but really the interesting part to me is the decision making. What compels you to do something like this to a person with this disease? And it's not always straightforward. It's not always intuitive. But essentially, what we're going to do over the next 30 minutes is try and tear through the evolution in the decision making and how it's been informed by our techniques and technology and methods and our other services, the oncologists and the radiation oncologists, right? So this lady, you can see how she started out, but then how do we make a decision about this person who has a T12 burst fracture with kyphosis, but you can also see sternotomy wires, and you can tell from the X-ray that she's likely frail in colloquial sense. This patient who had already been operated on for her breast metastases and now was recurring sort of at the top of her construct, which was already a little bit unusual. And this patient, breast cancer patient with tumor at C2 and C1, resulting in this somewhat unorthodox sagittal cut of a CAT scan. Right? You don't usually want to see an entire row of teeth in somebody's sagittal CT of their cervical spine. Decision making for these patients is complicated. Many of their treatments are invasive, but their problems are also very bad. So these are what I consider to be high amplitude decisions, right? Oftentimes you're putting someone at a fair amount of risk, but you're doing it in order to maintain something that we think of as very important, right? Some functionality, something like being able to look horizontally or walk around. So these decisions are important, and the way that we make them certainly evolved over time. So we're going to talk briefly about how they've been made in the past. We're going to talk briefly about how we're making them today, and specifically how I make these decisions. And then we're going to touch briefly on what's going to happen in the future of these decisions, what we're hopefully going to be informed by, and some of the things that we'll end up doing as more and more patients get pulled into the surgical cohort, right? So to move it along, and sorry, we're going to go a little bit quick here. We'll talk about what we've been doing in the past, and as far back as I'm sure any of us can remember, we're talking about the 1980s. Nobody remembers anything before the 80s, in my experience. And if you look at the literature back then, it takes somewhat of a dim view of operating on specifically epidural metastases. Right, and this is, not necessarily a landmark paper, but certainly an emblematic one that, much like a lot of literature at the time, separated these patients into radiation alone and radiation plus laminectomy, and did not find much of a benefit for operating on patients. Right, the percent improvement that was determined in each of these papers that they consolidated was 16% per patient. So they determined it's more or less equivalent to operate on these patients or not. And in fact, as late as 1992, an article in the New England Journal of Medicine, and I'll just read it because the language is very strong, that several retrospective studies and one small prospective study failed to demonstrate a difference in neurologic outcome between radiation therapy and laminectomy followed by radiotherapy. And furthermore, laminectomy has been associated with an increase in morbidity, including instability, whereas radiotherapy alone, initiated promptly after diagnosis, has therefore become the primary definitive treatment for most patients with metastatic epidural disease. And gratuitous furthermore aside, it is not difficult to imagine that they were, these procedures were done rarely, although not never, and not considered to be state of the art. If you take a little bit of a closer view, one at the numbers, right? So even this study that consolidated several other studies had 29 patients in it. And in fact, if you look at the pathologies in play here, particularly in the group 1 who received radiotherapy alone, looking at breast and lymphoma are probably disproportionately represented. And those being particularly radiosensitive histologies, may have skewed the results of this already fairly small trial. But that's the data that we had at the time, right? And that's all the information that we had. And if you Move forward about another decade. Now you're talking about the advent and more widespread use of MRI technology. So we're starting to define these lesions more clearly. Also in the 90s, the dissemination of pedicle screws, right? So, people, the residents now and people who trained when I did think of pedicle screw fixation as just something that's always been, but it very much is not, right? It's a relatively new technology that's still being adapted and incorporated into our techniques and, more importantly, decision making when it comes to these patients. And then the last thing from the 90s, which was really published in 2005, is the Patchell study, right? And so this is when I was in training, this was the landmark metastatic spine tumor study. 100 patients enrolled over something on the order of 10 years, largely at the University of Kansas. Dr. Patchell demonstrated that surgery for a very finely selected group of these patients, he was very specific with his indications, neurologic deficit or a neurologic symptom, it was actually successful, right? And in fact, patients who were initially treated with radiation and then operated on when they failed radiation regained the ability to walk sometimes, but not as frequently as the patient who underwent surgery initially, right? So this was, for us, for me in training, this was the study that we cited when we decided that we were going to operate on these patients, right? This came out in 2005. I started my training in 2010. Even before this paper came out, the new technologies were being incorporated, right? People like Xia down at Hopkins and others were doing operations for metastatic disease, typically the more responsive tumors, the ones where you could keep people alive for a long time, are the ones for which radiation worked reasonably well. Renal cell, where patients respond reasonably well to therapy and benefit from surgery. But the real step forward came about 10 years later when the folks at Memorial Sloan Kettering started publishing widely their results with radiosurgery, right? And so if we think of the radiation treatment of this disease, there's essentially, what we think of as conventional radiosurgery, which involves wide beams that go all the way through the patient from one or two directions. They typically deliver low doses in course of many treatments, right? 10 fractions, 30 fractions. 30 gray over 10 fractions. Whereas stereotactic radiosurgery is familiar to us, or was at that time, largely through gamma knife, right? It's many beams crossing the tumor through from many directions that ultimately spare the surrounding tissues. And in this case, we're looking to spare the spinal cord, obviously, and then also, structures like the esophagus, which becomes extremely important when you're talking about the cervical spine. But by sparing those surrounding structures, they will deliver much higher doses, right? And these doses are frequently very much superior to conventional radiosurgery, particularly when we're talking about the so-called radio-resistant tumors, right? Things like sarcomas, non-small cell lung cancer, GI cancers, essentially anything other than your germ cell tumors, lymphoma, breast cancer, and prostate cancer, which still responds very well to conventional radiation. But essentially, this new technique sort of regarded everything radiosensitive. And these slides are lifted from Mark Bilski's talk, who educated me about during my training when I was at HSS. I was able to sneak across the street to MSK for a couple of months and really see this technique in action. And it was very eye-opening and certainly, I think, marked a big step forward in terms of the treatment of this disease. And they've been publishing, on this technique for the last 10 years, the technique specifically when it comes to surgery of separation surgery, right? So the one thing about radiosurgery is that it does drop off pretty quick in terms of the doses. They still need 2 millimeters. That is, the radiation oncologists need 2 millimeters of space between the tumor that they're going to treat and the spinal cord. And in cases where the tumor abuts the cord or surrounds the cord, oftentimes surgery. The point of the surgery is not to resect the entire tumor or even really debulk the tumor. The idea of the surgery is to get it away from sensitive structures so that the actual treatment for the tumor, which is the radiation, can be delivered in an optimal way. It's separation surgery, right? The technique as it's described or was described by Dr. Bilski and Dr. Laufer involves unilateral, bilateral pedicle removal, and essentially a wide laminectomy, followed by a transpedicular decompression, depending on what you need to do. And oftentimes that involves getting anterior to the spinal cord and separating the tumor from oftentimes the PLL. The PLL forms a natural border. Being avascular, it does pretty well in terms of stopping the tumor growth. And if you can get the PLL back where it is supposed to be, that's usually going to offer you enough CSF space around the spinal cord on your post-op imaging that the radiation oncologists are comfortable delivering very high doses to the tumor that remains. These surgeries are simple technically, at least the instrumentation parts of them. Sometimes the anterior decompression ends up being the hardest parts of a corpectomy. So they do present some technical challenges. They're essentially just a long construct, and then you make some room around the spinal cord. It's important in this cohort of patients to do it quickly and efficiently, right? These are sick people by definition. They all have metastatic cancer. So they oftentimes aren't as robust from a frailty standpoint as many other patients that you would more readily operate on. That said, you're oftentimes doing this operation to spare ambulation and achieve local control of spine tumor that you're addressing. All these decisions are made in the context of the treatment of their systemic disease, right? And I lifted this slide about 20 minutes ago from a short presentation by Dr. Johan. But there's other things other than just the radiation oncology advancements that are affecting our decision making and our treatment of these patients. And one of the big ones is that the medical oncologists are getting pretty good at what they do. And it's not surprising, as we are investing as a group of people, as a country, a lot of money in treating cancer, and the advances in immunobiologics and other techniques for systemic treatment have ended up making great strides in terms of the survivability of this disease, right? If you go back to 1975, you compare it to 2015, in terms of overall 5-year survival rates for cancer, they have gone up significantly, right? In 1975, you're talking about a 49% survival rate, and then in 2015, it's now 69%. And specifically with the diseases that we tend to see go to the spine, and ultimately, the number of cancer patients who end up with disease in their spine is very high, something on the order of 80%, depending on what kind of studies you're looking at. Histologies are living significantly longer, right? We talk about prostate cancer advances, 83% in the 80s. Now it's 99% 5-year survival. Breast cancer, 84% to 91. Renal cell, 57 to 76, right? And even lung cancer, which is, has a grimmer prognosis than these other histologies, has gone from 13 to 21%. So a 50% increase in terms of the 5-year survival from this disease. And given the investments, the $2 billion that the federal government's dumping into this disease, and just, as we can see from Medicare spending and on top of all the other research investment in this issue, these patients are only going to live longer and longer. And certainly that's good, but it's going to present what we think of as good problems in terms of surgical decision making, right? So it's not going to be as simple as it was maybe in 1980, where only in rare circumstances would you even consider operating on someone. Because of the Patchell study, and now because of separation surgery, we have these techniques that pull patients into our surgical cohort, which does not simplify the decision making, because every time you push things a little bit further in terms of what you can do, you're going to bump up against a challenging decision on that border of what, where's the threshold where we say yes versus no in terms of doing a surgery on someone, right? The decision making today, so if I get called about one of these patients, it's very easy to become overwhelmed by their medical issues and their complex history. I tend to think about it first by thinking of an indication for surgery and then trying to think of a reason not to do it. And in terms of indications for surgery, there are essentially three. And if you just think of these three things, it's going to get you pretty far in terms of at least thinking if someone can benefit from a surgery. The first thing, is not subtle. It's if there's a neurological deficit. If someone's spine tumor is paralyzing them, that's a reason to do surgery, which is somewhat intuitive, right? This is something that we've been talking about forever. You go back to the 70s, people are talking about it. It's a thing to do, and it follows that it is, we're compelled to rescue things for a neurologic basis, right? The second reason to do this operation is for mechanical pain. That is, if the tumor has caused some sort of an issue with the bone, the load-bearing structures in the bone, you think of facets, or a burst fracture that renders the vertebral body and the anterior column somewhat limited, then burdens the other more functional parts of the vertebral column, which then causes pain, right? And it's important to separate from, on a clinical basis, mechanical pain, which comes from instability, essentially, from biologic pain, which comes from just having a tumor in your spine. Having a tumor in your spine hurts. And it can be at times challenging to discern what we think of as biologic pain from mechanical pain. Oftentimes, the clinical diagnosis, if you look for a few key things, it can be helpful. Mechanical pain tends to be worse with loading, right? Somewhat intuitive. There is a paradoxical increase in pain, particularly in patients with tumors at the apex of their thoracic kyphosis, where their pain gets worse when they lie down as it cantilevers across that apex, and they essentially they load their joints more heavily. But essentially, mechanical pain hurts when you move around. Biologic pain stereotypically is worse at night, particularly in the 3 or 4 a.m. hour when the endogenous steroids dip. As such, it also can be relatively easily diagnosed simply by loading the patient with steroids. And if their back pain is very bad, and you give them tenodecadron and they feel much better a few hours later, that oftentimes can be very helpful with regard to discerning whether or not someone should have a surgery. So first indication, neurologic deficit. The second one, mechanical pain. People will talk about the SIN score. I'm going to kind of gloss over it. It's more of a referral tool, but it can be helpful in terms of trying to delineate instability through the spine. And then lastly, as we touched on, separation surgery. And for that, it's important to work closely with your radiation oncologists. They're almost a technician in that instance, right? They will tell me if they feel like they need more room, and if they do, and I feel like it's safe, I can get it for them, right? Mark Bilski says the radiation oncologists are the rock stars of this disease. And so in this instance, we get to take at least a little bit of a backseat, which is sometimes difficult for us. Important to let them drive the boat in this instance. There are some other adjuncts that are becoming more widely adopted, certainly things that I use in these surgeries that make everything a lot better. Steroids is important as a temporizing measure, right? So a lot of these patients come in through the emergency room. They are in some state of duress, usually weakness in the legs is what you typically see. But it oftentimes the surgeries are not simple, and the decision making isn't simple. And oftentimes you need a lot of participants when it comes to deciding how sick someone is in this condition and whether or not doing surgery on them is a good idea. So steroids are invaluable when it comes to buying us 24, sometimes 48 hours to get all the shareholders involved, have these what amount to fairly complex discussions about risks and benefits without the hourglass flipped over and watching someone deteriorate neurologically. Steroids are beneficial in that they arrest, for the most part, neurologic decline from this disease. Other adjuncts that are very helpful include embolization, particularly in renal cell tumors or thyroid tumors, anything that ends in angioma. In fact, as embolization has become more widely adapted, we'll embolize almost anything if there's time. It's certainly we found worth it to spare the patient a few 100 cc's of blood loss and what amounts to probably an hour of surgery, both of which allow them to come out the other side with a lot of momentum. Right, tranexamic acid, another important adjunct for limiting blood loss from these surgeries, and that we've started using more recently, adopted from the deformity practice. It's also important alloys that we use. Oftentimes, some of the complex alloys can make things hard for the radiation oncologists. That's why we stick to titanium. They sort of figured that out. There's also in smaller font here, the advances made in the PEEK carbon fiber rods and screws, which don't have an artifact and allow more easy deployment or more functional deployment of proton therapy, which has its use. We're not going to address that in the context of this talk, but certainly the materials that you put in the patient in this disease are important, and not just in the ways that we think of. They're important for their treatments that follow surgery. We've also started using in a more widespread fashion vertebroplasty augmentation of our constructs as we turn an eye towards their durability in the long term. And then also MIS techniques are at times helpful. And so we have plenty of ways to treat this disease, but still the decision-making can be very complicated, as I said. A very helpful tool is the NOMS framework. Essentially is just a way to organize your thinking, right? Also published at MSK. There are 4 factors: the neurologic status of the patient, their oncologic history, that is the histology of the tumor itself, and specifically whether or not it is radiosensitive, the mechanical nature of the spine, right, that we touched on, the stability versus instability, and then sort of grab bag, and in many ways the most important aspect is the systemic concern, right? Is this patient going to come through the surgery, if we do it, with enough momentum to have a good outcome? That's oftentimes the most complicated but important aspect of this decision making. And it's easy to think of this as an algorithm. It has a lot of arrows on it. It is, as an algorithm, extremely complicated. As a framework, it's far more useful. And certainly, if you talk to Mark and Ilya about it, it is more than anything just a way to organize thinking and just be sensible. These are the sort of considerations that we make most of our patients, or at least a slight variation on them. And it's just a way not to get overwhelmed with the complex nature of these patients. And if you're able to think about it in an organized fashion, everything becomes a lot less scary, and it's easier to form a coherent plan, be confident about it. So lastly, we'll talk about the way these decisions are likely to be made in the future. And this is very much informed by my time at UCSF, working with Chris Ames and his emphasis on more dystopian ways of making decisions. And think the artificial intelligence, machine learning, deep learning, right? He gets pretty scary with this stuff. And it's very easy to get overwhelmed. Something that I touch on all the time is Bonini's paradox, was essentially that when you develop a model that tries to delineate a system, as that model becomes more complete, it becomes more complex, and essentially ultimately becomes incomprehensible, right? And it's best summed up by this interwar French poet, Paul Valéry. I love this guy. I just love the look on his face. And it's down to everything is simple is false, and everything complex is unusable. And so as we delve into these more so-called advanced ways of making decisions, it's important to think about how precise they are and how easily deployable they are, right? In longer versions of this talk, I go on and on about the development of chess playing computers. I won't subject anyone here to that, other than to say machines are getting better and better at making decisions for us, particularly in closed or known environments such as chess, right, where all the data is right there in front of you, and even in poker, which is probably a more accurate model for the way we have to make decisions in this disease, given the number of things that we don't know, right? All the unknowns at play. Computers are also getting good at that. So they're coming for us, and frankly, it's good. But it is very easy to get overwhelmed by this. So I guess it's important more to think of things more broadly for this part of the talk. But there are a lot of advances being made, particularly in the deformity field, where we have large baskets of data that can be analyzed, works constructed that are projected fairly easily forward. The deformity world is very well organized. And at UCSF, they've started doing a lot of computer modeling, right? But we don't have to start with that just yet. We can look back, and people have been modeling this decision for decades, right? The Tokahashi score is probably the earliest, most important one. And it's more or less, it got it right, at least in terms of how we think about it now and its components. And components that you're going to see in all these scores are performance status, visceral metastases, histology, and most part, those are the big ones, right? And this has a few extras: the number of extra spinal bony mets, the number of mets in the vertebral body, spinal cord palsy, which tends to be redundant with performance status, right? So there's some redundancies here, but it is fairly accurate, right? By accurate, we think of what we use today. Now, I'm always suspicious of these lines that we see here that are drawn through maybe some scattery plots. But certainly it's a start, and it was an important one, and even went so far as to prescribe a treatment, right? If someone has a very high functional score, Tokahashi score, then consider doing a surgery on them. And if they don't, then don't. And then of course there's this penumbra, which you'll see in almost all these things where they kind of tell you, which is fine, right? And so this Tokahashi score has been revised. New ones made that have been simplified, right? And they all tend to have, again, the same components. It's performance score, it's histology, and it's the number of mets elsewhere in the body, right? And you know, they keep on iterating on this, and certainly we're getting better and better at it. The most widely used one now, or maybe the best one, if you want to call it that now, is the New England Spine Met Score, which is essentially a modified Bauer plus ambulatory function plus the serum albumin, right? People iterate these, they're getting better and better at determining whether or not someone's going to live, right? That's essentially what we're trying to model in these papers, is the survival, the likelihood that people are going to survive, 3 months, 6 months, a year. We're getting pretty reasonably good at that, and a lot of logistics and advanced computing techniques being used. Again, they all come down to pretty similar things: histology, functional score, number of mets, particularly number of mets elsewhere in the body. But they do also get pretty complicated pretty fast. These things get incomprehensible. And while maybe the scatter plots look a little bit better, they still are difficult to see necessarily as lines, or at least are very clearly defined by what may be relatively few points. That said, if you look at this graph, which is the essentially on which the entire field of adult deformity surgery is built, this is maybe not as liney as the big arrow would make you think. We're certainly getting better at gathering data, the technology like the EMR, and just sort of general consensus about the importance of large data sets is allowing us to gather more granular data in much larger numbers, right? And with these data, we're able to start looking in a more mechanical way, right, about the different components of prediction in these patients, right? And it's not just about survival. It's about their functionality, and in fact, frailty, as a term of art, predicts not only how long someone's going to live, but can also be used to predict their complication rates, specific complications, how they feel after performing patient-reported outcomes. Frailty can be what you want, depending on the outcome that you're looking for. In the deformity world, we've come up with a lot of different measures and ways of predicting how well someone's going to do with surgery. But also, it's not just one surgery, right? So again, in deformity, given the number of patients that have been well organized, they've been able to come up with scores that try to define the invasiveness of a surgery, right? We all kind of know that a T-tendon pelvis is bigger than a microdisc, but it can be hard to quantify, and we're making efforts to try and quantify these more correctly predicted, more precisely predicted, right?
Hey, Patrick, just a comment, 2-minute warning.
Yeah, sorry, thanks. Oh, geez.
Sorry to interrupt.
No. The outcomes that we're talking about in tumor surgery, we're fortunate in that there's essentially 3 outcomes, right? There's There's alive and not paralyzed, there's alive and paralyzed, and there's dead. When comparing with the rest of spine surgery, where we're oftentimes trying to compare how people feel, we benefit from a simplification in many ways in terms of how people are, we're going to be measuring our outcomes, right? So just to sum up, decisions in the past, we've gone from, laminectomy being completely not an option to present day where we use the NOMs and consider everything, consider our new technologies, and then with an eye forward, looking at how we can consolidate our information in what amounts to a political exercise to work together and try and determine the best techniques more finely. And even when the machines come for us and they end up making all our decisions for us, which will be wonderful, will certainly still be necessary in order to help these patients or guide the patients through these complex decisions, right? Because what is it on December 11th? So that's seven months after the patient treatment, we got a call from her daughter that she died. Walked around for 7 months, was relatively pain-free during that time, at least from a spine perspective. Trying to figure out if that was worth it is very much a personal decision that you do your best to give them accurate information and then figure out what they want and then help them get what they want. Even if we have a patient whose head is on sideways, we don't have to leave it like that just because she has metastatic cancer. There are ways to fix it, and people can do well with this disease, but the decisions are obviously complicated. Thanks very much. Thanks for your time.
Dr. Reid, thank you. Dr. Chowdhury?
Hi, Patrick. First of all, fantastic talk, and we're very excited to have you here. And this talk was an evidence of that. You're definitely going to help elevate the care, clinical care and research of this population here. We look forward to working with you on it. We don't have time for the extensive discussion, but you really brought up the prognosis question, and we have struggled with that in the past. Sometimes we operate and the patient doesn't survive very long, and occasionally we regret it the other way as well. So I think that, using data and other things would be very helpful, and anything you can do to help us in that, because I think it isn't perfect science. And so any comments you can have on when the eyeball test, the residents may come to me and say the eyeball test, they don't pass it, but the oncologists are pushing us to say the patient's going to live 6 to 12 months. What are your thoughts on that situation?
I think a lot of it comes from experience, right? Like, I was fortunate at Columbia that they called me for all these patients. And Uptown, we were documenting an ECOG, which is basically, a score, I don't know how commonly you guys use it here, but a 1 to 5 score that says, how sick does this patient look, right? And it's essentially trying to quantify the eye test, which is important. The New England scores, the other scores are helpful, maybe more for research purposes at that time. I'm not using it in my day-to-day decision-making. But certainly you got to talk to the medical doctors. You have to kind of fall back on your training in terms of, we're neurosurgeons. We've been dealing with sick people for a long time. And our clinical acumen is not negligible, right? And for the most part, you can make a ballpark decision and you address the risks with the patients to the extent that they're able to compute them themselves. You make a decision. And, for the most part, we're right. It's certainly regrettable when someone does not make it out of the hospital, right? That's a failure. But the important thing is just keeping track of how you're doing. And then as we consolidate our data, no one can really do it alone. Nobody has the numbers to say something interesting about a population of patients that's heterogeneous just for their own practice. It's a matter of getting together with everybody else and trying to organize this information to say something interesting as a group, which is.
Thank you. We'll work with you on that.
Patrick, congratulations and welcome. Look forward working with you. I started the spine radiosurgery program here at Sinai in 2007. So we were really early in getting this procedure to the patients. I just want to make a couple of clarification because you went through a lot of material super fast.
Yeah,
there is no gamma knife that is used for spine radiosurgery except occasional C1, C2, maximum 3. All the radiosurgery that we do is based on LINAC. And the concept of the separation in the 2 millimeters you alluded to was brought up to in counter argument to the fact that you needed to do a gross total resection of the tumor, you could now do much smaller operations. Although I still agree with Dr. Marguedes, who typed in the chat, if you can, always do a gross total resection. But the concept was really to be less invasive. And now with the new paradigms that we have, we don't need the 2 millimeters. And I'll be happy to go over some of those plannings as well. I think that as Dr. Chowdhury pointed out, that the way of the, and you did in your lecture, that the way of the future is really outcome, because it doesn't look good when the patient dies on the table, not on the table, but in the hospital after has been in the operating room. And so I think that is where we all want to partner together and to understand that if we take care of the tree, it's just one tree and there is a full forest. So I think that there is a lot of work that needs to be done, and it's great to have you as a partner.
Much.
Alex?
Hey, if there's time, thanks so much. Hey, Dr. Reid, I'm Alex. I'm one of the PGY4 residents. Looking forward to working with you. Just going off of Dr. Chowdhury's question, and I'm glad that you brought up the idea of prognosis, but from a spine surgery standpoint, can you talk about additional considerations you add to your decision-making paradigm in terms of considering rates of fusion in a patient that may not survive, say, more than like a year and a half, rates of pseudo, PJK, et cetera, that are often pretty important decision-making aspects for us in the DGEN population, but how do you incorporate these when you consider operating on this unique patient cohort?
Yeah, you almost needn't consider them at all now, right? Like, if you look at the MSK numbers, the hardware complication rates, hardware-related complication rates that they've had are something on the order of 2%. And, you know, that sounds like a great number, but it's because the patients don't live that long, right? Like the average survival is not, to say the least, what you'd expect from your typical degenerative patient. Now, it is interesting and important, I think, to look forward as I touched on, the oncologists are getting pretty good at their jobs. And so these patients are going to end up living longer and longer, right? And so over the course of our careers, it's not unreasonable to think that those hardware related complication rates are going to rise, particularly because these patients almost never fuse, right? And, you know, as we're taught, all constructs fail eventually if you don't get a fusion. So what's going to happen is that we're going to be in a race with the medicine doctors about who can do the better job, right? And if they beat us, then there's going to be a lot of hardware complications, you know, in years 3 to 5, right? In patients that we end up doing these operations on. So it's not a problem yet. I think that it's going to be, depending on how successful they are on the medicine side, and I think they're going to be pretty successful. So we're certainly looking at ways to both make our constructs more robust, you know, as I touched on, things like vertebroplasty augmentation of the screws, as the, you know, the halo rates in these patients are likely very high, because it doesn't last that long, right? Or things like alignment, right, which becomes something that kind of amplifies over time, may become more of an issue. And so we're hoping to look into that forward, as that'll likely, you know, that issue is going to ripen.
Great. Thank you so much.
Thank you, Dr. Reid. I know we're going a little bit late. I think we'll conclude here. Thanks very much.